This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Gregg Day from Mayo Clinic in Jacksonville, Florida. Today I have the pleasure of interviewing Sebastian Palmqvist from Memory Clinic Skåne University Hospital in Sweden. Sebastian is the lead author on a collaborative paper published in JAMA titled Blood Biomarkers to Detect Alzheimer Disease in Primary and Secondary Care. Sebastian, thanks for joining me today.
Thanks for having me.
If your practice or training extends back a decade or two, or maybe a little bit more, chances are you're familiar with the adage that we can't be certain that a patient has Alzheimer's disease until we do an autopsy. You may even have said these words yourself. And although there's still a sliver of truth to that statement, neuropathological analysis remains the gold standard and ultimate arbitrator in the dementia clinic. Successive advances in biomarkers over the past 2 to 3 decades really call that maxim into question. Enter the age of biomarkers. Avid listeners of the Neurology podcast know that Alzheimer's disease neuropathologic change can be accurately detected during life using several different biomarkers. Here in the US, the list of current FDA-approved methods includes PET scans with tracers that allow us to detect and map amyloid plaques in the brain, as well as tau tangles. Also, cerebrospinal fluid measures that similarly inform the presence of the hallmarks of cardinal neuropath findings in the brains of patients with Alzheimer's disease. And now the latest development, blood-based biomarkers. Sebastian, your paper explores the potential for increasingly accurate blood biomarkers of Alzheimer's disease pathology to transform our diagnostic evaluation of patients presenting with cognitive complaints. Before we get too far into the details, tell us what makes blood-based biomarkers so special compared to other available or established measures.
I think your introduction highlighted that. Back in the days, the only way to be certain that you had Alzheimer's disease was after an autopsy. And after that, we had in vivo biomarkers using cerebrospinal fluid, CSF, 80 biomarkers, which requires a lumbar puncture, which is invasive and not easily done. Or you could do an amyloid PET, which is not accessible and extremely invasive. So turning to blood, this has been more or less the holy grail of Alzheimer's disease diagnostics. So it could definitely revolutionize and make it more cost efficient and more accessible compared to what we previously had.
So accessible, minimally invasive, and repeatable. All good advantages that I hear you talking about. Now, of course, there's many different things we can measure in blood. So which blood biomarkers did your study focus on, and how did you choose these biomarkers out of the plethora of possibilities?
The main biomarker, I would say, would be phosphorylated tau 217, or in short, p-tau 217, which using this particular test is measured as a ratio to non-phosphorylated tau 217. And we and others have for a couple of years now, 4 or 5 years, shown that this seems to be the single most promising biomarker for identifying Alzheimer's disease pathology in the brain. And in this study, it was also combined with measuring the ratio of beta amyloid 42 to 40. And this is a biomarker whom is more known to be measured in CSF, where it works much better than in blood. In blood, it's not as reliable. But we and others have shown that if it's combined with p-tau 217, that combination can in some instances be superior. So that's why we chose these two biomarkers. And they can be measured using many different assays. And again, we and others have performed head-to-head comparisons between different assays and have shown both for the p-tau assay and for the beta amyloid assay, which were both developed at Washington University and then commercialized by C2N Diagnostic. We found that these are the most accurate and highly performing assays. So that's why we ended up using that as the primarily test in the study.
And the reasons to me why this is published in a journal with incredibly wide reach and particularly targeting general internists, family practitioners, is because you applied these established blood-based biomarkers to characterize samples in over 1,200 patients undergoing clinical evaluation for cognitive concerns, either in the subspecialty dementia clinic or family practice. So what are the major or most important findings of your study?
It is that we uniquely in this study used predefined cutoffs. Usually in research, you either don't use any cutoff at all, just look at the area under the RUC curve, or you, based on the sample at hand, try to establish some cutoff using a Uden index or something like that, but that's not how it works in clinical practice. So when we apply a blood test in clinical practice, we already have a pre-established cutoff. So that's what we started with establishing. And then we applied it prospectively. So we didn't collect plasma over several years and then analyze it at one time point, but we actually sent samples from both primary care and from secondary care, a memory clinic, bi-weekly to C2N diagnostics for analysis. And this is important to check for the stability of the test over time, which you don't capture if you measure everything at once. And a third highlight is, I think, showing the performance in primary care, because this is the first and in many cases the final point of entry for patients with cognitive impairment. Very few go on to secondary care. And that's because it's such a common disease. 1 in 5 women and 1 in 10 men will develop Alzheimer's disease dementia over their life course. So that also makes this a very unique study.
So tell us, what did the blood tests show using these predefined biomarkers sent frequently, like we do in clinical practice? How did they perform?
I was actually surprised about the performance in primary care. We knew that they had potential in secondary care with the selected populations that we see there. We didn't know how it would perform in these prospective analysis, but it turned out that both in secondary care and in primary care, the accuracy both for Alzheimer's disease, in short AD, pathology in the brain, and also for clinical biomarker verified Alzheimer's disease was around 90%. And what I think was most striking here is that we compared this accuracy to the performance of our dementia specialists and also primary care physicians after the standard cognitive evaluation, but before seeing the blood test or any other AD biomarkers. And I think this paper highlights that it is very difficult to pinpoint Alzheimer's disease just based on clinical evaluation. We found that the accuracy for primary care physicians was 61% for clinical biomarker verified Alzheimer's disease. And for dementia specialists, we see these patients every day. The accuracy was 73%.
So a marked improvement even on the ideal situation where we're running the show and doing our typical clinical evaluation. Impressive findings. Tell me a little bit about the comparison standard here. So we think of autopsy as the gold standard, but our patients don't find that very satisfying. So when you say that you've got excellent discrimination here, what are we comparing it to in this cohort?
Yeah, that's a good question. So the main outcome that we used was verification of Alzheimer's disease pathology in the brain. And this was in most cases verified using CSF biomarkers, the presence of both beta amyloid measured as a decrease in the A-beta 42 to 40 ratio, as well as an increase in CSF phosphorylated tau 217. And we chose that as the main outcome since this is what the test is supposed to measure, AD pathology. But as a secondary outcome, we chose the maybe more clinically relevant, which is a clinical Alzheimer diagnosis. And this is a slight discrepancy to the presence of AD pathology because you can have the pathology in your brain for many years, 5, 10, maybe 15 years without any cognitive symptoms. So in the secondary outcome, we also included that you actually had symptoms of the pathology.
Clearly coming at this from the angle that we as clinicians would be coming at it, which again makes, I think, the results that much more applicable to practice. Building on that, how do you see these results being applied in primary care? And a follow-up to that is, what about our subspecialty dementia practices? How should we as dementia specialists be using and applying these findings in daily practice?
The key follow-up questions after seeing the results here. And as I mentioned, there is great potential in primary care, improving the diagnostic accuracy from 61 to over 90%. But I think we need to move forward cautiously here because we need clear guidelines for primary care, because these are physicians that do not normally use AD biomarkers. So they need education and clear guidelines on whom to test and what to do with the test results. Because we don't want to, with this study, convey that you can just use a single blood test and based on that say if you should be diagnosed with Alzheimer's disease or not. Because as I mentioned before, you can have the pathology in the brain for many years without any symptoms. If you do not use these biomarkers as an add-on to the standard clinical evaluation, it will probably overdiagnose Alzheimer's disease and underdiagnose for cognitive impairments, such as other neurodegenerative diseases or maybe even non-neurodegenerative diseases that are actually causing the cognitive impairment. So we need to be careful. In primary care, we need correct guidelines. In secondary care, I think it could be more straightforward because there, at least in specialized memory clinic settings, we are used to using Alzheimer's disease biomarkers. I think in many instances, we can just switch from using CSF or PET and instead use a blood test. Maybe in some cases, we could go on to do CSF or amyloid PET testing if we don't feel that the blood test result is clear enough. But here, it's definitely more straightforward.
What I always like to hear in these discussions is that there's still a role for the dementia specialist out there, and I appreciate you clarifying that as well in both settings. Now, of course, we're focusing on the highlights here, the major findings, and that's what we want to be talking about. But we know that in any of these data sets, in any of our clinical practice settings, there are always populations where the tests don't seem to perform as we think that they should. Is there a subset of patients here where the tests seem to have suboptimal performance, or a group of patients where you might advise against ordering blood biomarkers?
Looking at the performance in different subgroups, I would say that one of the findings that needs to be highlighted, and this is not specific to this blood test, but to actually any test. So it's about the underlying prevalence. But what we found was that in those with just subjective cognitive decline, where the prevalence of Alzheimer's disease or the pathology is much lower compared to dementia, we saw that the positive predictive value, the PPV, was much lower. And this, I guess, is as expected based on a test with a given accuracy. If you have a lower prevalence, the PPV will go down and the NPV will go down. So that means in these cases with just subjective complaints, it can be used to rule out AD pathology, but I wouldn't trust a positive test result. But that's just, I would say, more in research setting and maybe relevant for inclusion in clinical trials, because basically, we do not recommend using these tests in patients without objective cognitive impairments. So it's not as relevant. But then you could also highlight the other way around. So if you have a patient with dementia and a phenotype that is highly likely to be Alzheimer's disease, then you have a very high pre-test probability. So your PPV will be very high, meaning that you can really trust a positive blood test, but the negative predictive value, the NPV, will go drastically down. So I wouldn't be as sure to trust a negative test result in that setting or that population.
So in those patients where we have a high suspicion, a negative result might warrant further evaluation and potentially additional testing.
Correct. That's how I would interpret it. And that's not unique for the blood test, I would say. It's the same for using CSF biomarkers.
You've taken great pains, both in the paper and here with me today, to really discuss the correct application of these findings. And those who are familiar with a certain genre will know that I didn't come up with this statement, but with great tests come great responsibility. So thinking of that statement, what are the risks of overinterpretation of biomarkers in our clinic patients?
Yeah, we want to be clear based on the results here that we are not advocating using this or any other AD blood test as a standalone test to diagnose Alzheimer's disease. It's something that should be integrated in the clinical evaluation and interpreted based on the symptoms, the test results, and other aspects. And that is mainly due to the fact that Alzheimer's disease pathology is very common. If you look into 80-year-olds without any type of cognitive symptoms, about 30-35% will turn out positive on a blood test like this. So this means that you should test individuals with symptoms that are likely caused by Alzheimer's disease, and that makes the interpretation much more easier. But I don't think this is something that's unique to Alzheimer's disease or this test. We have the same problem, for example, with prostate cancer and PSA testing, which can become positive many years before you have any symptomatic cancer. And it's also a very common disease. Around 70% of all men die with prostate cancer, but we shouldn't diagnose everyone with prostate cancer, only those that can benefit from treatment. So I think you need to take that into consideration when using the test.
I really like the way that you phrase that. And I think these tests you're showing are very sensitive to underlying changes related to Alzheimer's disease. But that doesn't mean that the presence of changes to Alzheimer's disease explains the patient's symptoms or is the only thing present in the brain of that patient. And I think the extension of this statement too, we've talked a little bit about patients who have some memory complaints but don't actually have impairment. So those with subjective cognitive complaints. You haven't come out and said it clearly, but no role at this point for using these biomarkers in addition to that PSA screening lipid test as part of the annual primary care screening visit. Would you comment on that?
Again, want to emphasize that we shouldn't promote this as some sort of test you can order at your local primary care unit if you're worried about Alzheimer's disease. At the moment, I only think it can help people if you actually have symptoms, and then you can test that individual, maybe start cholinesterase inhibitor treatment, refer to secondary care or whatever your local guidelines state. But that's how it is right now. I'm not sure this is how it will be in a couple of years. We will have to see the results from the preclinical asymptomatic Alzheimer's disease trials. And if those come out positive, then we might end up with a scenario where this is actually being implemented as part of a screening scenario. But we're not there yet.
You're absolutely right. It's a very quickly moving field, and we look forward to covering more on the topic here on the Neurology podcast. Thinking about applying this in my own practice. So what recommendations do you have for neurologists, those with specialty expertise who routinely see patients with cognitive complaints, who might be considering integrating these tests into the diagnostic approach for the patient with memory symptoms?
Again, I would like to emphasize that it shouldn't be part of some general neurodegenerative panel or something that you do whenever you have someone in your clinic with a suspected neurodegenerative disease. You actually have to think twice and think, do I believe that the symptoms that this individual has could be caused by Alzheimer's disease? And in those cases, I think it makes sense to order such a test, because then you can interpret a positive test result as highly likely Alzheimer's disease due to the pathology that you have found, but not something that we should casually include in every workup in neurology clinics.
But potentially considering blood biomarkers before we think about LP or amyloid PET. Is that the message embedded here?
It could be, but I wouldn't emphasize before. I think you could actually say instead of. We didn't show it in this paper, but we recently had a paper in Nature Medicine showing in head-to-head comparison with the commercially available CSF assays that this blood test actually performs similar to those tests when using amyloid PET as the outcome. So I think we can gradually transition in more cases to using just a blood test. And I say this very confidently based on data and so on, but having used this test for more than a year, I know that in clinical practice is not as easy, because we've actually tested it now for a year and a half on all our dementia specialists who have been using it. And even though they knew that this was a very good test, they didn't trust it in the beginning. Because we're used to PET, we're used to CSF, and it feels more real and more accurate. And then here comes this blood test, which is supposedly good, but we didn't actually trust it in the beginning. So I think in many settings or in many centers, there will be this transition phase where, as you say, maybe this is something you do before the PET, but as you grow more confident and not just looking at this in other papers, but actually getting a hands-on experience, then I think you can gradually transition more and more to using blood tests.
And in clinical practice, I think when the result comes back and it's well within the positive range or well below the positive range, I think there is a tendency to assign more confidence to that. But I'm thinking now of the very first patient I ordered CSF biomarkers in, and a patient who I had some suspicion of Alzheimer's disease, but definitely the test was going to change my mind. And wouldn't you know that the test result came back directly on the line. So what do we do with these patients if we're getting a result that might be considered intermediate level or perhaps even indeterminate?
Somehow we tried to tackle this here. So we used one single cutoff to have a binary result, but we're actually also testing using two cutoffs, and upper and the lower ones, you get, as you say, a very clear positive zone and a very clear negative zone. But then we have these intermediate ones. And I guess one thing, at least in secondary care, that you could suggest in these cases is to go on with amyloid PET and CSF testing. This is easy to suggest in guidelines. I think in practice, it will not always come out the way you hope, because What we've found here and in other studies is that these intermediate results truly are intermediate. So I wouldn't call them indeterminate. Most of these individuals have intermediate amount of pathology because that's the way the disease works. Gradually, over decades, the pathology builds up in the brain. It depends on the situation and the testing. Maybe it's something that you can test again in a couple of years or a year or something like that. But this will be tricky cases, definitely.
And perhaps an opportunity to take a step back, reconsider the differential diagnosis, and think about other tests that may help to identify a co-pathology or other driving factors.
Definitely. If you have severe symptoms and only intermediate amounts of pathology, you should, as you say, definitely consider other alternatives.
In the few seconds that we have left together, can you summarize for me what you consider to be the key take-home message, the thing you want our listeners to remember about this collaborative study?
I think this shows that blood-based biomarkers have for many years been promising, but now I think we're at the point where we can actually say that this is something, if using the most high-performing assays, this is something that we can trust and actually start working with in clinical practice. But the next important points is to have guidelines. And I think these will need to be national or even regional, because they are very much dependent on the healthcare system and how the flow between primary and secondary care works.
Thank you, Sebastian, for taking time to discuss this important paper with us.
Thanks for having me.
I've been speaking with Sebastian Palmqvist, lead author on the paper titled Blood Biomarkers to Detect Alzheimer Disease in Primary and Secondary Care, a paper which you can and should read in JAMA.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.